Good afternoon, and welcome to Samaritans First International Health Forum. Thank you for joining us today. We hope that you will all participate in our conversation, and you can do that through the chat box, which is right next to the video screen. Before we begin, let's open with a word of prayer. Our most gracious Heavenly Father, Lord, we just come to you today. We're thankful for the many blessings for all that you have done for us and through us. And Lord, as we go into the presentation today, I just ask a special blessing over the presenter and the work that's being done throughout the world. And Lord, use this talk to glorify you. In Jesus' name, amen. Today, our guest is Dr. Louis Zirkle. Dr. Zirkle graduated from Duke University Medical School and began orthopedic training at Duke. He was then drafted by the U.S. Army and sent to Vietnam, where he served in 1968 to 1969. Dr. Zirkle finished his training in the U.S. Army and at Shriners Hospital for Crippled Children in Los Angeles. He practiced in Richland, Washington from 1973 to 2006 and left to devote his full attention to Sign Fracture Care International, the nonprofit organization he founded in 1999. Sign Fracture Care International has performed more than 240,000 surgeries for poor patients throughout the developing world. Today, Dr. Zirkle will present the journey of the Sign Nail. Dr. Zirkle?
Thank you, Cindy. I'm very happy to be here. We talked at the Samaritans Purse conference last time, and I'm impressed with your organization. And we'll look for ways we can work together and I'll explain that challenge that we all have of increased numbers of fractures in developing countries. Next slide, or the first slide. Could you go back one, please? Our vision since we started is creating a quality of fracture care throughout the world. This vision is very important to us, and we've kept our eye on the vision of equality of fracture care throughout the years since we started. Next slide. When we started, I didn't know the different types of learning that were necessary. We had to address all of them, and I'll tell you how this occurred. And I must say I made mistakes as we went on this 20-year journey. Our 20-year anniversary will occur in March. The first type learning is episodic, and we have events that happen to us that influence us in our daily actions for our entire lives, and I'll tell you about some of those. Declarative learning is the usual learning that we think about in terms of text, lectures, webinars, internet, books, and procedural is very important to surgeons because we learn things in episodic and in other surgeries, and then in declarative from reading, and procedural means that we practice them in developing countries in the case of Sign, and this is very important. Next slide. Episodic, these experiences stay with us, and one of the parts of episodic learning is empathy. Sometimes empathy comes from your mother, or it has to be learned. Next, please. This was a big episodic learning method for me. I was drafted out of my residency and sent to Vietnam in 1968, as noted by Cindy. I was assigned to be commanding officer of a K team, which was the connector between the medical helicopter detachment, which picked up the wounded after and during battles, and the 93rd Evac, which was the hospital in which I worked. We risked our lives to pick up military, U.S. military, both and Vietnamese military, But also we picked up civilians after the battle, and I felt that they should be treated because we risked our lives to pick up them also. We were instructed to send them to another facility. The other facility was not adequate. I visited it, the personnel weren't adequate, and the facility wasn't adequate. So I asked Generals Abrams and Westmoreland if I could treat these patients in our hospital. So I was assigned a whole wing in the Quonset hut. The hospitals were made from Quonset huts in those days. I give a lot of tribute to the nurses, to anesthesia who worked extra to help us care for these people, and for the people along the evac chain who sent us the hardware to treat these patients. The U.S. military were evacuated out if they needed hardware. We were not allowed to place hardware in U.S. military, but we had to give the whole treatment to the Vietnamese on this ward, and we treated many Vietnamese. Incidentally, we stopped getting rocket attacks at night when we started doing this. Wynn came in. He's an 11-year-old boy. He didn't look this healthy because he was very emaciated. He had been burned by napalm, and he had a 90-degree flexion contracture of his knee. He couldn't walk, which was just horrible for an 11-year-old boy. And so we had a talk, which was mainly by gestures, and I put him in traction and gradually decreased his contracture, rehabilitated his muscles, and when he could walk, his father was notified. When his father came to visit him, he had to come a long way on a bus. As he and Wynn turned around to walk away, the father gave me a mango. The mango had a thumbprint in it, and I looked at that mango and looked at Wynn walking away, and I thought that this was the best gift I'd ever received. And that was the beginning of a quest for creating a quality of fracture care for the people who had no choice in their treatment. Next. This man also was an episodic event. I was very interested in treating the poor and went to Indonesia every year for a month to give lectures. We sent over containers of instruments and implants. I then transferred my activity to Vietnam, and one of my students asked me to return to Indonesia to visit him. I did, and came upon a ward with many patients like this man. He had a fracture of his distal femur. He had been 3 years in this bed. His family quit coming to see him because they couldn't afford the hospital charges. And I looked at my former student and said, why? We talked about this in lectures many times. And his answer brought me up short. He said, yes, I remember how to treat these fractures, but he cannot afford an implant to treat these fractures. And by the way, he said, these containers of instruments and implants you send over, we can't use because we have power surges and we can't use power. And the implants in United States are designed for power with power reaming, in our case of IM nails, and the image intensifier for real-time imaging. And I realized with a sinking heart that I had wasted 10 years. So I returned to the United States determined to do something about this in an effective way. Next. We started working in garages on butcher bone and on PVC pipe. And the first thing we did was to design the nail. We designed it for the tibia, and you notice this nail has a straight shaft with bends at both ends. The bend at the proximal end is for additional stability, and the bend at the distal end, we rotate it when we put it in so that it creates a little bit bigger channel, and it works very well. And it worked very well with the tibia. You notice there's no enlargement in the proximal end as there is in all US-made femoral IM nails. Next slide. We then thought maybe we could use this in the femur, and so we did testing through getting C-arm first, through getting CT scan first, and then making images. This is American femur here, Vietnamese femur. Actually, we got one American and about 10 Vietnamese and about 10 Bangladesh people who lived in Richland. If you look closely, you can see the arc of radius, which is the curve. And the curve is not the same amount, but it's the same in all femurs. And you can look at the differences in the width of the canal. So it was more economical if we could use femur and tibia. We wanted to fit canals around the world. And as luck would have it, and by the way, Sign is blessed and lucky in many instances because Sign nail follows the helix in the proximal femoral canal, which gives it additional stability. Next slide. This was our first surgery in Vietnam. This was done by closed reduction. And I give the highest tribute to the Vietnamese surgeons. They're excellent surgeons. They're very interested in treating the poor. And we immediately became great friends, and they treated a lot of tibia fractures. Next. This girl came in, and she had a fractured femur as well as a tibia. And we thought about this. How can we treat this femur and tibia combination? As we often do in Sign programs, we thought about it that night, and we decided we would put the nail through the tibia and then use the retrograde approach through the intercondylar notch to place the nail through the femur. To our knowledge, this had never been done before. People were treating the femur with nail, but they were putting them through the side. Mark Swinkowski devised this. And when we looked into this more later, found that actually there were 2 papers out about this. But this worked, and they sent me pictures of the patient standing on her fractured leg at 6 weeks. We communicated back then by mail and by pictures. And so it took a little time, but this really encouraged us. Next slide. So our surgeons began to use more and more retrograde approach to the femur. And then we wanted to evaluate how well we were doing. And so we got pictures of the flexion of the knee and pictures of the patient squatting. And that's the beginning of our squat and smile picture, which we feel is very important for assessing healing. Next slide. I then received a letter from my friend Han Kwai Kwan, shown here in the picture on the left. He and I became very good friends, and he said, I put the Sign nail through the proximal femur, through the greater trochanter. And I thought, oh, we're going to have to design a new nail. Because at that time, the implant companies in the United States were designing nails which could be placed in the proximal femur instead of the Kuncher nail. All of these nails had enlargements in the proximal end, and the sign nail did not. Dr. Kwong, this came from him and his idea. He said, no, he said, you don't have to design a new nail. He said, you can just use the sign nail and let it rotate where it will as it goes down the canal. And this has been our technique. And we have not changed the nail anatomy since we started sign. And I give, again, great tribute to the Vietnamese surgeons. Next. The Indian people need a good stable base of the humerus because they eat with their hands. This man had had 6 operations in India. He had the sign nail, and I was very impressed looking at this, looking at how far down this nail went distally. You would think that he would not have good flexion like he does. So we're studying that, and we continue to learn more about treating fractures. Next. These little sayings that I have put up, we make a theme of each sign conference, and these are our themes which apply. Marcel Proust said the voyage of discovery, which is in our case the voyage of discovering and innovating new nails, consists not in seeking new landscapes, but looking with new eyes. So we looked with new eyes at the way fractures were treated and fractures at different parts of the body. Next. We still do declarative learning. Declarative are, we have conferences around the world. This is in Afghanistan. And I was so humbled that these surgeons came over insecure roads to come to this sign conference because they're very interested in learning. And this is the case around the world. We're in all the military and all the civilian hospitals, in many of them at least, in Afghanistan. And where a sign is run by a general in the army in Afghanistan. Next slide. Procedural also is used, and this is our simulator. I often wondered for many years, what's happening inside that canal? How come I can feel the nail, but I can't put the slot finder in the slot? And this is how we found we could find the slot without using imaging, is our slot finder. We can do sign nails in as short a time as 20 minutes. So these surgeons, as they develop skills, become very good at putting the slot finder and the screw through the distal interlock. In fact, many of our surgeons in developing countries actually are not trained surgeons, but they've adapted to sign, they do it well, and they report their cases, and we counsel them, and we talk over the surgery. Next slide. Procedural also means sawbones. This is again in Afghanistan. And you know, we look at people around the world and they're remarkably similar. We're all the same. And we have patients that we're very concerned about, and we want to learn how to treat them properly. Next slide. The ultimate hands-on procedural learning is in surgery, and this is again in Afghanistan. These surgeons are excellent surgeons, and my goal is to help and work with them, and they've become great surgeons. I am humbled now because every surgery is reported on our database. I'm humbled by the difficulty of the fractures they treat, many of whom have been non-healing and infected fractures. They get very good results. Next slide. So the sign model became, at the instigation of the man in the bed, education, plus donation. We have to donate the implants because the poor cannot afford them, and they have to be appropriate for use in developing countries. Next. Each case, each surgery is reported on the Science Surgical Database. And you might say, why do they report? They report because we send base replacements based on the sizes and based on their reporting. And now we're getting more and more reports from 3 months and longer until the patient is healed, because these are really the orthopedic surgeon's report card is the long-term patients with the fracture healed or not healed, so we can learn from both. Next. Next slide. We live in a scientific community here with Patel, and so we have a lot of interrelations and interactions with the scientists. And the scientists really emphasize observational studies and then modeling. So our goal is the best possible surgery for all SINE patients. So we now have a database. We've done 230,000 cases, and we have a huge database. It's the largest in the world that we're learning from, and we're making queries to learn more and more from in observational learning. We're looking at new ways to evaluate, including artificial intelligence and machine learning, so we can give the best care throughout the world. Next slide. We have a problem, though. We have a continuing challenge. Even after 20 years, injuries and trauma account for 32% more deaths than HIV, AIDS, TB, malaria, and diarrhea disease combined. And for every death, there's 15 to 35 disability. So we want to prevent that disability, and that's our goal. Next slide. The poverty is decreasing throughout the world. It allows families to buy a motorcycle, which they can buy for $500. And this motorcycle becomes the family vehicle. It becomes the vehicle in which the father or mother go back and forth to work. And these vehicles crowd the road, and there's more fractures. They cannot afford treatment for their fractures. And WHO statistics show the family spirals into poverty for 3 generations because they have to take the kids out of school if they have no money, if a wage earner is hurt. And we want to prevent that spiral. Next. So the challenge is that poverty is decreasing, motorcycles are increasing, and fractures and injuries are increasing. And that's our goal, is to decrease the disability from these fractures. We now have over 300 SINE programs throughout the world. And we look for Samaritans Purse to work with us and establish new programs and treat more fractures. Next. These fractures crowd the emergency rooms. This is an emergency room in the capital city of Addis Ababa, the biggest hospital there. And the patients can't get a bed on the ward. So this increase has not been accounted for, but is beginning to be worked for in developing countries. Next slide. This increase is also shown on the ward, where the patients are waiting to get in the operating room to have surgery. This is an operating room in the Philippines where they're waiting to have surgery. Next slide. So how can we solve this? We can do more surgery. We can do faster surgery. and we can do better surgery so there's not revisions and so that patients heal faster. And we're working on all three of those components. Next slide. We're working on more surgery by establishing more programs in developing countries. And you can see that we have a lot of programs now. We couldn't put all the stars on, but we want to treat the poor, and these are the poor countries in the world. Next slide. Faster surgery can be done with our fin nail. It's faster because you don't have to do the distal interlock, place those screws. When you place those screws, that's the longest part of the fracture, that and the open reduction. And this came about by accident because I was in Bangladesh very soon after going to Vietnam and starting the sign nail. And I went there and I brought hand drills to place the holes. And I didn't know that much about sign. So the hand drills kept skiving off the bone. And we tried to get one more case in, and we were working on this case, and the reamer got hung up in the canal. We couldn't get it in, we couldn't get it out. The time was ticking. And finally, we got it out, and I left in great discouragement from Bangladesh. And then in coming home, I recognized the book by Michelangelo was very apropos to sign as we developed sign, the agony and the ecstasy. And this was agony. Next slide. I realized later that the fixation comes from the fins embedding in the canal, but also the three-point fixation from a straight nail and a curved canal. When I was home, I was still in private practice, and I ride my bicycle back and forth. I still remember the place on the bike path when I said, wow, we could solve this problem if we could put the reamer flutes at the end of this nail. We wouldn't have to put the distal interlock, so we wouldn't have that frustrating part, and it would be a much quicker surgery. And we've developed this process and assayed the surgeon's opinion about it and assayed on the database, and it's almost as effective as any nail in the world. And we're still determining the word almost because that occurs with subsidence, which is collapsing of the fracture site. And we're working on this. Next. You can see that this is a retrograde approach, and you can see that this fin nail embeds very well. It's three-point fixation, and we really encourage all retrograde femur nails to be done with the fin nail. Incidentally, the femur is the most common injury that needs an IM nail. We have a big series of these, and they're very successful. Next slide. It's successful because you can put the interlocking screws in and compress the fracture site very easily just by tapping the locking bolt. Next slide. It also means you don't have to put a stress concentrator in the high stress area of the femur. When you make a hole for a drill, for a screw, you make a stress concentrator, and if this is in the high stress area, which it is in the femur, if the patient falls, they can fracture. And this is a big case because you've got to go through the knee, take out the nail, you got to take out the screws first, and then you put any grade nail in. So this doesn't happen often, but when it does, it's a big deal to the patient, and we want to avoid that. So we have a large series, and we recommend the retrograde fin nail for retrograde femurs. Next slide. This was studied. We have independent people study. This was from Canada, studying the fin nail. They first of all studied the sign nail and found that it was equivalent to any nail in the United States and Europe. And then I asked them to do the fin nail, which they did. They had computer ways to measure the stability. The fin nail, as I mentioned, was very successful. Next slide. I first said to the sign surgeons, let's start this by only using this on stable fractures where the fin ends up in the isthmus. As usual, the sign surgeons decided that they could do more indications, and this has really brought sign forward. Next slide. This is that same patient. It healed well. So these surgeons know more than I do, and they do what they consider the right thing for their patients. Next slide. We're very interested in the humerus. If you read the literature, most people recommend putting a plate on the humerus. In conflict areas, we see many fractures right in this area, and therefore we get a chance to see the treatment of these fractures, mostly in Afghanistan. And you can see this fin nail was placed, and the fin is in the level of the fracture. And so you might at first glance say, this is not stable. Next slide. 3 weeks later, it's maintaining reduction. We insist on follow-up. Next slide. And 4.5 months later, it's healing very well. Next slide. 7 months later, it's healed. And look at his motion and look at where that end of that nail is. So we're studying this, and it works really well. Excuse me. Next slide. The fin can be used in our pediatric nail. This is a little boy in Mongolia who was a jockey of a horse. The jockey fell off. The horse came in without a rider. And this is him standing on his leg the day after surgery. This is his fracture healed up at 2 months. So we're very happy with the pediatric nail, and more kids are being injured because of the motorcycles. Next slide. This is again pushing the indications because that's what people do, the sign surgeons. This is a fin nail. You notice that's a very narrow shaft, and we chose a 4 millimeter shaft because it can bend. It's the largest shaft size that can bend, and kids tend to remodel. But then we developed a 6 millimeter, and now we use the fin nail, which is very good. So we're pushing the indications here, and I'll talk more about that. Next slide. You can use the standard fin nail, which works very well for the older child. Next slide. I want to say that now we're treating pediatric nails through the retrograde approach. I mean, placing pediatric nail through the retrograde approach. This has a long history. I saw a bunch of sheep going to market in Addis Ababa, and I thought, let's try this out on sheep. So we went to a veterinarian's office and we put Shan's pins right in the middle of the intercondylar notch. The orthopedic surgeon took him to his home and took x-rays and did pathological studies later, and there wasn't much change. Case Western Reserve has followed this through more sheep studies, and then we found out that the surgeons in Mongolia were putting them in human adolescents, and I said, you can't do this. We're FDA approved, and we're not FDA approved for this. And of course, they didn't pay attention. They continued to do it. And I said, I'll cut you off from all nails if you don't send follow-up until the patient has finished growth. And this nail is a revolutionary idea. It's been presented at the Pediatric Orthopedic National Meeting, and I think we'll go forward with it. This is another discovery by sign surgeons. These are gunshot wounds, blast wounds, and then we can put the nail in a lot earlier. We don't take out the bone, and they heal very quickly. Next slide. You can see the healing at 6 weeks. Why is this? Next slide. You can see the squatting smile in this young man at 4 months. If you hearken back to his fracture, it doesn't look like that's possible. It's possible because the cortical bone stem cells are stimulated by mechanical. And we don't want to shoot all our patients to increase healing, but we can certainly use a bone mill. So we developed a bone mill for this, and we're studying this now, getting long-term results using the cortical bone. Many of you, as I have tried to cut the cortical bone and put it in the fracture site with a rongeur. It's really difficult to do. Next slide. So this is our bone mill. We, of course, use the drill cover. And this is grinds the bone up very well. And we're studying this in 10 different programs. Next slide. Michelangelo's prayer is, Lord, grant that I may always desire more than I accomplish. With the sign surgeons probing what's possible, we desire more, but we're accomplishing as much as we can. Next slide. We're making a new reamer. So we're looking critically at all aspects. We're looking with new eyes. We've been now using our reamers now for as long as 20 years, and they're getting dull. When a cutting edge hits another metal, it becomes dull. And so we've developed a sharpener. They can sharpen the reamers, and this gathers more bone. We've become very enchanted with the idea of more bone put in the fracture site, so our fractures heal quicker. You can see our current reamer and our old reamer. We're currently redesigning our reamer. And we also have a flute to take the bone out of the flutes of the reamer. It's called a flute scraper, so you don't have to use metal to make it dull. Next slide. When I was in Afghanistan, they treated femur fractures and they treated hip fractures for 3 weeks in traction and then put them in a body cast and sent them home. Well, it's freezing cold in Afghanistan, and we got electricity, as did everybody else except the U.S. Army, 6 hours in the day, and we didn't know which 6 hours that would occur. So you could go to bed freezing and wake up very hot, or you could go to bed very nice and warm and wake up freezing. And can you imagine being in a body cast like this? And this is, again, the episodic learning. Next slide. So we want to treat fractures. We want to treat all hip fractures, not just the stable. And we wanted to treat the unstable, but we could only have one system, so we made it modular. So all fractures are treated, and our success rate is very high, though this is a harder fracture to do than the femur shaft. Next slide. Our goal was to treat unstable and stable fractures. We didn't want to make a big hole in the lateral femoral cortex because this can lead to a fracture. We wanted to be able to compress the fracture, so we developed and innovated a compression screw. And we wanted to address the deforming forces because it's not just going into varus when they become deformed or lose reduction. It's an external rotation they go into. So doing it in the lateral position prevents that. Next slide. This is our template. We ask everybody to template because, again, they're not using a C-arm. You know, a lot of the programs have C-arms, but they're not working. They're broken. So this is the picture of our SHC, or sign hip construct. You can see the two compression screws. We could only have room for one interlocking screw. We also put a plate. We started off with a fin nail. We didn't have enough room in the femoral head because I was working in Myanmar, and we designed this for the small femoral necks. Next slide. This is our plate. This is called the HV plate. It's high visibility because we don't have a C-arm. We wanted to be able to look at the fracture. Now this plate has been modified. It worked very well for the femur, and you can see those large apertures in the plate. So you can use our nails and our screws. But when the canal narrows, in the isthmus, you have to have a smaller 3.5 millimeter screw. So we redesigned that plate. Next slide. We started off doing load to failure, very crude. We had a hydraulic press, and we would crank up that press, and then we'd say it's cracking. So everybody would put their head down or leave the room because we often had chips flying around. And this worked well, but I thought this is not the way hips fail. Next slide. They fail by repetitive fatigue. Two young men came. One was a medical student. He had been to MIT, and then he went to UW, to medical school, and then he took a year for MPH in public health, and then he went down to UCSF for his orthopedic training, back to Harborview here for his trauma fellowship, and he is a very active sign. He's on our board now. The other man became an engineer, and then he went into medical school, and he's doing very well. It was very interesting. They would come and visit. They didn't know each other, and I introduced them, and they developed this. They designed this whole thing, which was very impressive. There are about two kids. We would go swimming before we went up here, and came up to sign here. And they were cannonballing each other and having a good time. And then when they came up and sat down, they matured about 20 years. And they've continued to work with us. It's been a joy. And I want to make sure a lot of people understand that sign is the work of many different people. Next slide. We went back to Afghanistan and did this man's hip. And here he is with his family, mobilizing. Our physical therapists are the family. Next slide. This is what it looks like. We didn't need the plate here. Next slide. This one, you can see our indication for the plate is that the fracture comes out below the interlocking screw. Next slide. This patient needed a plate, and you can see the treatment here, 2 compression screws, and they're not perfectly placed in the center, but remember, no C-arm, and they heal very well. Next slide. We also have to treat combinations of hip fractures, subtrochanteric fractures, and intertrochanteric fractures, and they do well. Next slide. We want to treat femoral neck fractures, and you notice that the intertrochanteric and the basilar neck fracture are very close. Next slide. This is something you don't often see. This was in a book came out of Hungary about the posterior part of the femoral neck. And this, I think, is why they don't do well. Next slide. So we had to give good stabilization. There's a debate about, do you do the inverted V or whatever? I just think they need to be placed circumferentially near the wall. Next slide. So we began to look at the subtrochanteric fractures, and this is the value of the database. This is not a good result, and therefore we started using the plate on the lateral femoral cortex. Next slide. There's a lot of deforming forces in a subtrochanteric fracture. There was an exhibit at the AAOS, and 40% have either loss of reduction or implant breakage. Next slide. So we began using our nail plus a plate, and this has worked very well. As I review, I'm very happy with the results. Next slide. This is our new plate and our new benders. The plate, you can go to the next slide. The new plate, next slide, please, can be used in the hip, subtrochanteric area, the distal femur, non-unions. And so we're looking for areas in which we need additional stability. So the plate has made a journey just like the nail has. Next slide. This is a distal femur. The question is, should you put a plate in or not? It's very convoluted. Next slide. We put the plate in and it healed up and did very well. Next slide. These long oblique fractures are in older people. They're difficult to treat, and you can see that it's easier for them to subside. Next slide. So we wanted to hold them. We developed a collinear clamp that can be used in pelvic fractures also to hold them, and now we're working a better way to add stability. We're looking at the difference in fixation between just a screw going through the cortices, a screw and a nut, and a screw and a plate. Next slide. And this is the stabilization using a plate, and that works real well. Next slide. I want to just emphasize this. This looks like it's a good reduction. Usually I ask the audience if they think it is. Next slide. It's not. It's not, because the fracture occurs where the canal is widening, and these need retrograde approach. Next slide. So this was revised to retrograde approach and heal. Next slide. So we want to define what we mean in the indications. It's not necessarily distal, middle, and proximal. We want to define them based on the anatomy of the canal. Next slide. Our first 20 years reminded me I was in Pakistan, and these mountains are in Pakistan. And I thought of a saying by Nelson Mandela, who says, I've been climbing the mountain. I'm working very hard and I'm really tired, but I know when I get to the top of the mountain, I'll have a rest. But when I got to the top of the mountain, there was another mountain to climb. And that's very analogous to sign. We've reached the top of the mountain after 20 years, but there's another mountain to climb. I won't have time to go into that, but we're working on a lot of new ideas and new ways to treat fractures. Next slide. Observational is still very important for us, and we're going forward like this. Next slide. We also want to have better intercommunication among surgeons around the world. And so we're allowing surgeons to join our hub. Next slide. So thank you very much. We take questions now. These are Maasai women who had the three of them had fractured femurs for 4 to 5 years. They didn't even seek medical help because they couldn't afford it. And our surgeon found them, and we operate on them, and now they're very happy. Next slide. I think that's all. So I can take questions now.
Okay. All right, thank you, Dr. Zirkle. Just a reminder for our viewers to please post your questions for Dr. Zirkle in the chat box, and we will move on to that. In the meantime, though, while those are coming up, I just wanted to go ahead and ask you, Dr. Zirkle, in the work that you've been doing, what is the oldest fracture that you have had healed that is noted in your database?
Yeah, I hate to admit, but I can't hear that.
Oh, I'm sorry. Can you hear me now?
Okay, say that again.
What is the oldest fracture that, from a chronic fracture, what is the oldest fracture that you have seen healed through the SiNail technology?
Can you type it out on the chat box?
Let's see. I think they're working on that. Are you still not able to hear me? Can you hear me now? Is that a little bit better?
I can hear you a lot better now.
Okay, sorry about that. So I just had a question with regards to the experience that you've had with SiNail over the past 20 years. Can you recall, what is the oldest fracture that SiNail technology has been used to correct and heal?
The oldest fracture. Yeah. Are you
Yeah.
talking about the oldest patient or the
No,
oldest fracture?
not patient, like a chronic fracture.
We have had fractures that have been present for as long as 6 years that I know of.
Mm-hmm.
And they have healed with sign. Those 3 Maasai women had been 5 years, and they healed. So I think that's why we're very interested in the stem cells with cortical bone.
Okay, very
Thank you.
good. On average, how many campaigns does SiNail do per year, as far as going out and doing the teaching and the training?
Average
Number of campaigns, number of times that you go out to the different hospitals and do training per year.
So, it says no more questions. You can do the wrap up. So,
Okay.
You did have a question though.
Well, yes, I was just wondering if there was an average number of campaigns, number of trips that are done each year, going out and doing the teaching and the training that SiNail does.
We have very good training electronically on our database.
Mm-hmm.
And we also, the way signs spread, it usually spreads from one surgeon teaching other surgeons. And we are finding around the world, leaders are coming up to be sign surgeons. The average number of new programs we start each year is 30. And so each one of those has between 2 to 10 surgeons. And before we start a program, there's an application form. And they write in about the number of patients they would treat, the facilities, what equipment they have, if they're treating charity patients, which is very important also.
Mm.
And if they fit, and we've got 8 we're doing. If they fit, we arrange. They can go to another signed program and learn, or if the surgeon in another program takes an interest, he can often will take his set and go and teach in their own hospital, because you have to teach the nurses as well.
Mm-hmm.
And I'm hoping that Samaritan's Purse will work with this and start new programs. You know, you have some very active hospitals. We were just talking before we started about Tenwick and Kajabi in Kenya, which are Samaritan's Purse hospitals. And so they also train our surgeons. One of the Tenwick trains a surgeon from South Sudan. I guess what I'm saying is the training comes digitally, electronically on our database through questions. They always ask questions of me, and I answer every day. I also review the database, and many questions come up while they're doing the surgery, and they put them in the comment section, and I answer them. So that's how it occurs.
Okay, very good.
We're finding mentors that are coming up and becoming leaders. We're starting to treat pelvic fractures now.
Mm-hmm.
And we have the only pelvic fracture fellowship now in Africa. And this was started by 2 Ethiopians and who took training in Toronto, actually. And it's very well done. They trained one of our surgeons from Sudan who does pelvic fractures in Sudan. So what I like to see is this spreads by the people in those countries with the observation of others. And I have to tell you that I learn more than I teach when I travel.
Well, that grassroots interest and everything makes it a lot more sustainable, especially with the support from your organization.
Yeah, the database is important.
Mm-hmm. Well, thank you very much, Dr. Zirkle. I just want to give everybody a reminder that there is CME credit available for this session. So there should be a form with instructions on how you can request those in your email. And we will also be sending a follow-up email with that information as well as a link for the recording. If you are not already on our email list, we would like you to go ahead, if you'd like to, join the forum at health.samaritans.org, and then that way you will be the first to know of any upcoming events. Our next webinar will be on Wednesday, March 13th, so you want to be sure to join us for that. So I'd like to thank everybody for joining us, and Dr. Zirkle, thank you very much for your wonderful presentation.